Good morning, everybody. First of all, I must thank APAIO and especially Dr. Inder to be with you. My job has been simplified by the previous speakers, especially Dr. Nalini, Dr. Marwa, and Dr. Manpreet Kaur. Say where we were and where we are now. That's my area of discussion. I've been fortunate to be associated with this specialty, with this program, since its inception in India. When I was a resident, then SR, and when this program was started in 1978, and I joined as SR in 79. So my HOD used to take me to those areas, and I said, sir, what I will do? He said, you will see what is happening there. And the program started in NPCB, and in Nirban Bhavan, lot of meetings, lot of discussions, and people used to tell their stories, the advisor from various states. And what was the state of affair before that we are going to discuss. I don't know who have seen those eras, maybe Dr. Inder or Dr. Nalini or few friends who have seen those traditional camp approach and what community ophthalmology definition used to be, that people were being operated by the quacks at that time. Those were the days. So we have passed through that journey and we achieved a lot, but still we need to do more, because we have been playing with the jugglery of figures. I think Rohan will agree with me. We have been saying that since long that we are going to achieve our target, that 1.4 to 0.3%, but we don't know where we stand till date. After so many years, so many programs came, Vision 2020, and say achieve the vision by 2020, but that also has passed for the last 5 years. So let's say what used to be. We have seen that era of these surveys. The priority used to be National Trachoma program, where we have seen people with inverted lids and complications and blindness and whatnot. Those were the days. And then vitamin A deficiency surveys. Again, that used to be a big problem. Before 80s, I am talking. And the community of thin was limited only to the few places. That means we used to treat them at a fixed base hospital, or if at all some NGO came in, we used to organize the camps in the rural areas, in a school or in a dharamshala or anywhere, by compromising so many things. So then Patricia Bart defined this. She came with an idea that why not to take care of these people, this blindness program, with the use of public health knowledge as well as with the use of community knowledge. That means, of course, in case of trachoma, environment, sanitation, pure water was playing big role. And that's why she felt the need that why not to utilize this specialty or this knowledge to use for taking care of the blindness. And at the same time, the community ophthalmology knowledge for educating the people, for say doing surveys, for detecting the problem, and unless and until we know the magnitude of problem, we can't solve it. So for knowing the magnitude, we do have that knowledge. Before it is, and of course now it is also, some of the NGOs were in the field, like Lions, Rotary, Sight Saver, established by Sir John Wilson in 1950s. He was the gentleman who donated all his property and started this NGO. And later on, he formed IAPB, and he was the first president of International Agency of Prevention of Blindness. So he was bent upon convincing the people. I had the opportunity to meet, I was talking with Naomi, that he came to, for delivering a lecture and for, say, giving us the diplomas when I passed my DCH from Moorfield, London. So I had the opportunity to meet that man. And I saw that man who was not even a medico for attending all the conferences, ophthalmology conferences, international conferences, and delivering the lecture and convincing the people, convincing the ophthalmologists that what you can do in this area. So that was the zeal of the person. So role of NGO is very important, I may tell you, as say Nalini has pointed out or other colleagues have pointed out. Then National Program for Control of Blindness came in 1978, and we were fortunate that the government at that time, say, adopted it under Prime Minister's 20-point program in 1982. So the stress was laid under this program to educate the people. I may say education is very important. And how I got motivated, I will tell you that when I joined as an SR and I later on as an AP, and I asked to do a medical board for a person who came there. My HOD marked it. And I was in pains in declaring a person unfit who was selected as a DSP in Haryana, having amblyopia in one eye. Look at the situation. The person is having 6/6 in one and 6/24 in other. And I had to say him that, gentleman, you are not fit for this job. And there was no remedy for that. So look at the pity of that man. Had somebody educated him during his school days that, or screened those children and did help them, he would not have faced that problem. And another example was a gentleman having color blindness was to be declared unfit by me, that he was not fit for the job of his security service. So look at these situations, why these situations arise. If we are vigilant, or if we play our role screening the children in the schools and telling them that, look here, these are the jobs for which you are not fit. And even nowadays they have done some relaxation. People with color blinds were not declared fit even for MBBS admission. But later on his condition was relaxed, and now they said that yes, you can do the study, but you can't be declared fit for a government service. So these were the situations, and that's how we can help these people if we are vigilant enough. So the stress was laid on infrastructure development, health education. That means whatsoever are the facilities existing, we must strengthen these at the primary level, at the secondary level, as well as at the tertiary level. That was the aim of this NPCB. Of course, the stress was laid by declaration of the Alma Ata on primary health care, because very important. Because everything starts from there. As say my colleagues have told, that there is a disparity. Lot of ophthalmologists are there in our country, but there is an urban-rural bias. So we can't press or we can't force the ophthalmologists to be in the villages, but at least we can serve in the villages while sitting in the cities. Now again this program was renamed. Why? Because it's not blindness which is important, visual impairment is equally important. Because if somebody is not fitting into the definition of blindness, that vision less than 3/60, still there is a problem with the people who are visually impaired. So under this program, the more stress was laid, whether it was Vision 2020 or it was NPCB and VI, the stress was laid that we should approach in a pyramid fashion. That means we should lay stress on primary eye care, secondary eye care, and tertiary eye care. And apart from that, the center of excellence or the apex institutions. In those days, RP center used to be the apex institution, but now there are 5-6 more institutions. We are playing a great role to be an apex institution. What is this DBCS? So under this national program, it was planned that we should lay more stress on the district level, in the secondary level. And there how we can approach? because people who have been working in the government setup, they know the hurdles, they know the bottlenecks. Where lies the problem? If somebody wants to purchase equipment for his hospital, there was a long channel. So DBS was, it was simplified that we should make a society and we can go through or we can solve these problems, these society approaches. Then it was included along with other programs and it was renamed as District Health Society. Instead of only focusing on the blindness, certain other diseases were included, and at the district level the civil surgeon was empowered to make a society that is a District Health Society. Now what we have been doing, that has been discussed, I am not going to repeat it, that outreach, screening camps, health education, training of health worker was equally important. And in this I may tell you, because as we are talking about that there is a dearth of say ophthalmologists, but at the same time there is a scarcity of these people at places where we can't reach. So how to reach them? So an idea came and said we can train even the school teachers. And when I looked at the literature, there were so many publications. In 95, one of my colleagues, Hans Limberg, who happened to be my classmate in Moorfields, so he did the job in India and screened almost 4.5 million children with the help of school teachers by training them. So still you can train them in the schools and they can do the, I will take few minutes on. So with the help of school teachers, we can get the vision screening done and they can refer it. And a lot of studies have been conducted. If you search the literature, they play equally good role as the optometrist, or the hardly there is a difference of 5-6% data. Then came the era of IOLs. So it was not limited to those ICC and the fake glasses. IOLs were introduced and we can provide the same quality of services to the rural folks with the help of this new technology. So what is now? Dr. say Manpreet has talked about it and so many other colleagues also, that it's not limited to cataract approach only, because there are other diseases which are equally important. Diabetic retinopathy, posterior segment diseases, glaucoma, which may cause a permanent blindness if you do not take care. So in those cases, the teleophthalmology plays a role, and naturally with these gadgets, by training the people at the primary health centers, at the vision centers, we can place the gadgets there and reach to these peoples. So we can bridge that gap of urban and rural with this. We can play a role in preventing the blindness for getting into, and it is cost effective and efficient because you require less manpower, and sitting at the cities you can examine and you can give opinion to these people, and you can do the screening, you can do follow-up, you can do emergency consultation. Suppose there is a patient of acute congestive glaucoma and the guy sitting at the PHC doesn't know what to do with that. So with your opinion, you can guide them that look here, you can manage this patient like this. So there are few advantages of teleophthalmology as we have discussed, but there are disadvantages also. And what are those? That there is a limited diagnostic accuracy. We can't give that facility or that opinion which we can give by examining a patient, but only just by looking at the data. There are limitations. Then technical and connective issue in the villages, net is down. Somewhere the facilities are not existing and the people are not able to connect to you. So that is the problem. Lack of skilled personnel. The person who have been assigned the job, he doesn't know how to update the data, how to load the data. So these are the problems. Then of course legal and ethical, because in these cases we are likely to miss something, and there is a limited scope of treatment while sitting at a distance, and of course it requires cost. Thank you very much.
Thank you, sir.